de hoy. A continuación tendrá lugar la conferencia plenaria del profesor Stephen Moritz, titulada Entrenamiento metacognitivo para la psicosis. Bueno, decir que para mí es un placer poder presentarles, puesto que precisamente le conocí cuando fui a una conferencia suya. Y bueno, puedo decir que son ese tipo de intervenciones que no te dejan indiferente. El doctor Moritz es profesor de psicología y catedrático en neuropsicología en la Universidad de Hamburgo. Ha participado en más de 50 proyectos de investigación, todos ellos financiados por fondos públicos, y principalmente se ha centrado en el estudio de la psicosis, un tema en el que es una persona con un amplio y reconocido prestigio internacional. Sus proyectos actuales, como nos comentará ahora, se centran sobre todo en el desarrollo de intervenciones de base cognitiva o metacognitiva a través de Internet. Y bueno, fruto de su trayectoria y solo por decir algunos datos, cuenta con más de 500 trabajos y más de 24.000 citas, lo cual es impactante. De todos modos, lo que no me gustaría olvidar es su actividad asistencial, porque la ha desarrollado tanto en el Departamento de Psicología y Psicoterapia del Centro Médico Universitario de Hamburgo, como en una unidad clínica de neuropsicología de la que es codirector. Y bueno, quería aprovechar para comentaros que en esta, a través de su página web, ponen a disposición de toda la comunidad científica una serie de protocolos muy estructurados de tratamiento metacognitivo y también de formación de e-learning para profesionales y que están traducidos a diferentes idiomas, creo que se incluye en castellano. Considero que es una opción muy recomendable. La última aportación que han realizado es el desarrollo de una aplicación móvil de autoayuda para el trabajo metacognitivo y añadir que es gratuita y de libre acceso. Por todo ello, pensamos que la trayectoria del profesor Stephen Moritz es un ejemplo de cómo poder garantizar la accesibilidad a los tratamientos psicológicos y poder así contribuir a la mejora de la salud mental. Sin más, thank you, Stephen, for being here today. And congratulations on your amazing work. It's your turn.
Yeah, dear colleagues, first of all, thanks for the invitation and for the introductory words. I could understand most of it. Actually, I took Spanish lessons in university, but yo hablo como un niño de 2 años, so I lost most of the Spanish in the last years. In my talk, I will deal with a metacognitive program which I've devised with my colleagues in 2002-2003, especially with my colleague Todd Woodward from Vancouver, but also my team in Hamburg. It's called Metacognitive Training, abbreviated MCT or EMC in Spanish. And the idea of metacognitive training is to teach patients about thinking about one thing. That is really at the core of metacognition. And in MCT, we are especially targeting those cognitive biases, those cognitive distortions which are implicated in pathogenesis of positive symptoms, so delusions and hallucinations. And prominent treatment targets are, for example, overconfidence and errors, so that patients are too sure about perceptions and memories, or inflexibility. And patients should reflect on these biases and to gain greater insight into their practices. But what exactly is metacognition? Metacognition is somewhat a strange term. It's half Greek, it's half Latin, and like many psychological terms, there are different ways of how to define and to examine it. And here are just some examples. A classical area of metacognition is to contrast subjective versus objective impairment. As clinicians, as you know, for example, depressed patients, sometimes they have subtle neuropsychological difficulties, but usually they exaggerate it subjectively. So patients with depression always feel as if they are demented or have severe memory problems. So there is a gap between objective and subjective functioning. And in schizophrenia, we have sort of the opposite. So patients often overestimate their cognitive abilities. Then modifying false beliefs about one thing is at the core of metacognitive therapy by Adrian Wells. And this teaches patients functional ways to deal with worries or negative symptoms. For example, one of the prominent techniques is detached mindfulness. I guess many of you have heard about that. And this is also incorporated in the metacognitive training. Then there's another area, it's called merit. It's by Paul Leisiger, who has done a lot of research on metacognition, who also has another understanding of metacognition. For him, metacognition basically is knowledge about one's own mental states and the states of others. And the way he defines metacognition is actually quite close to social cognition or to theory of mind. Myself, I have an experimental psychology background. Here, the ideas of the Israeli researcher Asher Koyak have been very influential. And in experimental psychology, confidence is regarded an core aspect of metacognition. And this is one of the main mechanisms of the metacognitive training. So we want to plant the seeds of doubt so that patients are more cautious, are more reflective about their cognition. Now, the big question, who was the first with metacognitive training? Was it Adrian Wells, myself, or Paul Leisiger? Neither of us. So actually, the construct is quite old, so it dates back to the 1970s, and the first metacognitive training already surfaced in 1985. And here's a study from 1987, and the construct was originally applied for developmental psychology, research in children. Here, for example, this is a study on patients or young patients who might now be labeled as attention deficit disordered. So they were contrasted to those who were more cautious, and those with attention deficit disorder were taught to reflect more on their cognition. So this was sort of the first study on metacognitive training, but of course this is quite different how we do metacognition now with patients with psychosis. If you're interested, I've written a number of articles together with Paul Leisiger on the deep roots of metacognition, and we have published these articles to show how CBT, how MCT according to Wells, how EMC according to us or Merritt by Leisiger map on different aspects, but we also show some overlap. So if you're interested in these studies, I can send them to you, so just send me an email. I will now go through the program and I will show you the basic structure of the MCT, and later I will also touch a bit on meta-analysis. So there are now 5 or 6 meta-analyses out showing the efficacy of metacognitive training. It's a group intervention for 4 to 10 patients, although we also have an individualized version called EMC Plus or MCT Plus. And sometimes our groups have more than 10 patients. This is of course not optimal because it leads to neglect of individual problems. The training is also augmented by videos, which you can download for free from the internet. And it's quite easy to administer. So of course we want the psychologist to administer the training or psychiatric nurses, but it's also open for example, occupational therapists if there's no psychologist available on board. And the training is quite easy to administer. We have written a short manual, about 35 pages, which you can download from the internet. So it's also available in Spanish language. And we have 8 to 10 modules that we recommend to administer twice weekly. So one cycle is completed within 4 to 5 weeks, but we have a second cycle so that the learning aims are better internalized. And the thing is open source in 2 ways. So one thing is it's donation-based, it's for free. Of course, we would like to have donations for the manual and for the material, but if you cannot afford that or your hospital is absolutely okay if you use it at no cost. And we also do not just hand out the PDF converted slides, but you can now also download the original PowerPoint slides. So if you do not like some exercise, you want to replace them, you want to edit them, that's absolutely okay. There's so much therapeutic wisdom in people on wards that we do not want to recommend that. So you can really shape it to your needs, to your experiences. And it's also okay to blend metacognitive training with other interventions. So there are some trials already out where metacognitive training was blended with metacognitive therapy or social cognition programs. So this is absolutely okay for us. We've now also devised a smartphone, which you can download for free from the App or Play Store, so iOS or Android. It's called Cogito, and we call it the toothbrush for the soul. Because you know that dental hygiene is not maintained when you go to the dentist twice a year, but it's best to work on your teeth, but also your mental health daily. And patients get push notifications twice daily that show them evidence-based exercises. So some are from metacognitivo training, others are from ACT or from CPT. They should work on that, and then they get medals and an umbrella open. So there are also some gamification elements in that. And we have already published 2 studies you can see there with beta versions of that app that show that this is effective. And the app is available in 30 languages, including Spanish. But for Spanish, not all the program packages are translated. And this is a transdiagnostic app, so we have program packages for people with psychosis, but also those with gambling disorders, OCD, chronic pain, and we are now working on a module on porn addiction, and I talked to one of your colleagues here, and we might also devise a program package on eating disorders. Now, these are the languages in which metacognitivo training is translated. So there's a Spanish version, there's also a Valenciano or Catalan version, but I was promised that whenever there is someone in the group who does not speak Catalan or Valenciano, then the therapist will switch to the Spanish version. So I hope that they will keep their word. And so you can download this from the internet, just Google metacognitivo training, or here's the website. And so we've translated in all major languages except for Urdu. So except for Urdu, it's really available in all world languages. And we also make cultural adaptations. So the Spanish or the English or the German version is quite different to the Japanese version or to the Arabic or Turkish version, not only language-wise, but we also made cultural changes. And again, you are absolutely allowed to make changes to the MCQ, so it's open source. I will now go through the different modules. We have modules on attribution, then jump to conclusions, which really is the mother of all cognitive biases. It's so important that we put it into 2 modules: inflexibility, theory of mind, and also memory, whereby we do not address cold cognitive functioning, so not cold memory, but it's more on qualitative aspects of memory dysfunction. And in recent years, we also devised some modules on mood, dealing with stigmatization and self-esteem. This is because there are some articles showing that if you ask patients, what are the symptoms that bother you the most, where should treatment be directed? It's not hallucinations or delusions, but they say it's self-esteem, it's stigma, it's depression, and of course, I think in psychiatry or psychology, the sort of the customer will never be king, but I think it's very important to consider patients' preferences, and this is the reason why we incorporated these aspects. But the main reason is to work on cognitive biases that we would like to straighten. In my talk, I will use 2 different frames. On the left, or like here, a white frame, so that's for the theoretical background when I talk about evidence. And then on the right, you've got somewhat a bluish frame of the thinker of Rodin in the upper right corner. And these are the slides that we show to the patient. And I will later show you some of these slides. And I want you to take the role of patients so that we interact with it. And the MCT has a typical sequence or logic, which I will go through with the example of module 2. This is on jump to conclusion. So we always introduce a session with daily life examples, for example, here, what are advantages, what are disadvantages of jump to conclusions, and then jump to conclusions in action. So we pursue the aim to normalize, to show that to errors humans, we all make cognitive biases. We all have cognitive slips. And here we show some common cognitive errors, and also we deal with common conspiracy theories that are not only very popular in patients with psychosis, but in the general population. For example, the myth that Paul Carson was replaced by a doppelganger, or that the moon landing was staged by the American. But of course, we only deal with conspiracy theories that we are able to falsify. But of course, we do not want to say that, well, we are all a bit crazy, but we make clear that some of these biases are escalated, are exaggerated in patients with schizophrenia, and that they lead to psychosis symptoms and problems with daily life. And so this is, for example, shown on this slide. And then shortly before the exercise, we have a slide asking why are we doing this? Well, we confront patients with empirical evidence on cognitive biases in schizophrenia and why it is important to work on these biases. And then the exercises start, and in I think about 2 or 3 minutes, I will show you exercises for most of the modules. Then we also have a slide on transfer of everyday life, so the learning aim, so that we wrap it up and patients learn what the module is about. Then we also have homework sheets that wrap up the sessions, that summarize the content of the module. But I think this is also your experience that many patients dislike homework or they forget it, and this is where the Cogito app kicks in, where again you get messages with push notifications, so you don't have to have an intact memory in order to be reminded by the exercises. Then patients after the first sessions are handed a yellow and a red card, a bit like in soccer, and on the yellow card you have 3 Socrates questions that patients should ask themselves when they feel spied on, controlled, persecuted. What is the evidence? What would significant others tell me? And even if I'm correct, so even if the police or the Guardia Civil is behind me, am I perhaps overreacting with my behavior? Now to module 1, this is on attributional style. It's a very prominent cognitive bias. We know from a lot of studies that patients with schizophrenia have a tendency to externalize blame and to credit themselves for positive events, and then they also have a tendency for monocausal attributions, so that they do not consider different causes but converge on one cause. And here we confront them with everyday examples, so short vignettes, and they should engage in a brainstorming what has led to these events. So, for example, here you enter a room and then everyone is silent. Paranoid attribution would be, well, they were gossiping about me, but it could also be that the conversation was over, or that they were irritated, they were distracted, or it was just coincidence. So often there are different causes, there are different possibilities why a situation came about, and this is something that we want to bring across to patients. Or here, someone says to you that you do not look well. Well, it could be that you are a bit pale or that you look ill. It could also be that this person is not very considerate, because no one really likes to hear that one does not look good. Or it could be the light. For example, I never look into mirrors in elevators. And so, again, there are often different aspects that could come together and create such an event. Then jump to conclusions. Again, it's a very prominent bias. It says that patients with schizophrenia have this tendency to make hasty judgments, so in view of very little information. This seems to predispose to delusions and to problems in everyday life. And here we show patients fragments that later depict an object. And then after each fragment, they should rate and re-rate their intuitions for either predefined alternatives or to self-evaluated ones. And some of these items are fairly easy, some of them are more difficult, and they should learn to consider evidence before making judgments. So they should only make a decision when they are really sure. So what's your intuition? What will this item later be? Yeah, most patients say, well, okay, this is for kids. Of course, this will be a lemon. But MCT is about correcting experiences so that they should learn the disadvantage of making snap judgments, so it later turns out to be a fraud. Or here it looks like a fish or a river scenery, and then later it's a mermaid. And we have another task set that was inspired by Philippa Garrity, which really is the marker of cognitive bias research in schizophrenia. We show pictures that seem to depict only one or two things. For example, here, most of you will see an old man with profile. Now I enlarge the picture, and if you look closely, it's still this old man from the side, but then this whole scene collapses into a street scene, and what seemed to be the hand on the jacket eventually is a dog lying on the street. In order to bring across the point that sometimes a conclusion does not lead to errors, but you often omit or neglect certain details in order to come to a more holistic conclusion. Then in module 7, we show patients painting, and they have to deduce the title. And we ask patients either to stretch their hand if they are 100% sure, or if they think, well, it could be this option, but I'm not 100% sure, then they should raise their hand immediately. And again, this is one of the core mechanisms of MCT. We want to plant the seeds of doubt because it has a tremendous effect or different effects on your well-being. If you think 100% of what STD is behind you, or if it's just 50%. So you want that patients decrease their confidence. And now a question to you. Who thinks it's buenas noticias? Please raise your arm. Who thinks la morte del niño? Are you sure? Or yeah. Okay. And the third one? And then the last one. Las noticias. You were correct. Why did you choose it?
I don't know, maybe she's crying, there is a soldier there.
Yeah. I mean, your response is correct. I didn't give you much time. So a number of you were wrong, but if I've given you 1 or 2 minutes, I guess most of you would have used the correct title. It is the fourth one, because you can really see a letter on the lap of the lady, and then the soldier has a second uniform at his arm, so which presumably belongs to the fallen husband. And then, I mean, I don't have kids, but I guess the skin color of the baby is quite normal, so there's no hint for a dead baby. And then this is from the semantic acquisition test. So, what do you think? Is it the first one? Please raise your arm. So like this when you're really sure, and this if you say, well, could be like that. So first one? Yeah, and the second one? Okay, and then third one? Yeah, well, we wouldn't show that to our patients, and then the fourth one. Okay, and again, you had very little time, so I sort of, lured you in this trap. And again, if you would have been allocated more time, most of you would have had the correct response. If you look very closely in the room, there's a bullseye, so it's on a ship. So perhaps the couple has just been married and he's showing his real face, and got drunk, and she's shocked, and the correct title really is, why did I marry him? Because, I mean, think of your grandpa or grandma, I think they didn't date for years, but sometimes just 2 or 3 weeks, and then they married and, didn't really know each other. And, sometimes then such situations happen. So, what about this? Please raise your arm. Who thinks it's number 1, it's tiger? Then Adolf? What do you think? Okay, okay. And then the third one? And then the fourth one? Okay. Actually, this. So, it's just to demonstrate what do we want to accomplish with module 7. So, don't be too sure about your intuitions. And as I said before, we are also dealing with conspiracy theories like that the US has been infiltrated by secret societies. For example, I think most of you know this, that there is this parody, and then there are rumors that the Freemasons had a big influence in the US. And there also is an owl somewhere here, and people say, well, that is a Satanist symbol, and there are also 13 arrows and stripes in the flag, which could be a Satanic symbol. And we are discussing with patients the pros and cons for these conspiracy theories, but of course, eventually, we then can solve this and falsify the conspiracy theory, which is a miniature model of a delusion. And what do you think is this? Most people think it's a rock concert, and it's a cotton picking machine. So, this is one of the examples where also you as non-psychotic audience made a mistake. Then module 3 is on changing belief. This is very important because the second delusion criterion, according to Karl Jaspers, is incorrigibility. So this is really at the core of delusions. But there are a number of studies showing that patients with schizophrenia are inflexible per se, so they also have such problems in delusion neutral exercises or instances. And here we discuss with patients different possibilities, what will be shown in the pictures before. So many think, well, this is the fourth priest, or he's preaching wine, water, but drinking wine himself, but then eventually it turns out that he's taking care of disadvantaged people. Then we have theory of mind first order, so that's the fourth module. We have a lot of evidence showing that patients with schizophrenia have problems with social cognition, so they have problems with empathy, to read, to perceive social cognitions, mimic. But this is not confined to patients with schizophrenia. So patients with autism, with depression, also with OCD, sometimes have these problems. So it's transdiagnostic, but still problems with social interaction can fuel psychotic symptoms, and therefore we think it's a very important aspect, and we've incorporated in the training. And so we teach patients that it's very important to gather social cues and also to increase overconfidence. Because again, we have overconfidence in patients not only regarding conspiracy theories, beliefs, but also regarding memories, appraisals, and other aspects. And this is quite easy even for patients because we have rich contextual information. This is apparently a marriage, and yeah, the bride looks quite happy. This is pain, and yeah, this is anger. I think that's John who's kicking my ass because he spoken badly about his mother. But here things are more difficult. And again, I want you to raise your hand if you're really sure or halfway you can put it out. Could be right, I would not really bet money on it. So who of you think this is the marathon? So number 1. Okay. Then number 2. Number 3. And number 4. Okay, so yeah, sometimes we discuss with patients already which marathon is it. Is it the Hamburg Marathon or the New York Marathon? And then most people say, well, it could be closely before the finish line because the style is very exhausted, but it's something different. So, of course, facial expressions can be misleading, even for us, although we are experts. What do you think here? Who thinks it's number 1? Please raise your hand. Who thinks it's number 2? Number 3? And number 4? Okay, you were quite good. Usually no one raised their hand with number 3, but it's number 3. So, yeah, this is from the 6th module, theory of mind second order. It's about to emphasize with another person and then to deduce what this patient or person thinks about another person. So socially you have to think around the corner. It's also about need for closure. And here it's about what will the girl give her grandma as a present for next birthday. And of course it will be toffees again because there's no way that the girl knows that grandma detests toffees because in front of the girl she said, well, they're delicious, I like them. So This is far more complex than the recognized first order, which we deal with in module 4. And this is a bit macabre, and I need a volunteer here. Who of these guys is a psychologist, a sportsman, an actor, or a serial killer? Amparo, would you perhaps do it? Who is the actor?
The first one.
The first one. And who do you think is this? Serial killer? Okay. And this one?
Not serial killer.
Yeah, okay. This one? Quite good. So actually, it's normal to have none of these guys correct. And so the first one is the sportsman, the serial killer. He's the actor, and then Alfred Adler. He's the one who coined the term inferiority complex, and usually he's regarded as a serial killer. So. And just to show patients that, of course, with mimic, with faces, you cannot deduce the inner life emotive of people. And I'm not sure if I have time, otherwise I could show a little. No, I don't think so. And so, yeah, this is in a nutshell the many cases of Dennis Peppo. So cheerful, excited, happy, irritated, always with the same face. Now it's about memory. We know that patients with schizophrenia have learning disabilities. They are bad with encoding. It's not so much the retention. And in some papers we could show that actually the memory is not that bad as often quoted. And if you control for poor motivation, for distraction through worries or hallucinations, then the large effect sizes shrink to medium effect sizes. But this model is not about cold functioning, cold memory, but it's on meta-memory. We know that patients with schizophrenia have a lot of meta-memory problems, that their memories are, for example, very vague, very pale, fragmented. But we could also show in a number of studies that they are overconfident regarding their memory. So we all have memory gaps, we all make memory errors, but usually these are held in check by doubt. Whereas patients with schizophrenia are more sure that these false memories were in fact correct. We present a rather prototypal scenes, like for example here a beach scene. Many of these pictures are from Norman Rockwell, who portrayed the white America in the 1920s. So here's everything that you would expect on a beach, or perhaps not. But we have erased two things, like in the other picture, that we would expect in those pictures, and later we ask what patients recall. And again, to show them that our memory is flexible, that it doesn't work like a DVD recorder. So please look at the picture, and then I'll have some questions. So, did you see it from Bria? Okay. Salvavidas? Carol? Pelota? Banista? Agua? Agua, sí.
No.
Then sombrero and toalla. Yeah, you were forewarned, and therefore I had sort of a presentation effect. But if you were naive, 60 to 80% of you would have had false memories, because when we imagine a street scene, then a beach scene, then of course we think about people lying on towels, that there are boards, and these were erased. But these are often confabulated by patients with high confidence. And again, in this exercise, but also in other exercises, many of you were wrong, but you shouldn't worry about being psychotic, because what really distinguishes people with and without psychosis is this level of confidence that people without schizophrenia are able to exert doubt, to say, well, it could be this, but I'm not sure. This is what we want to achieve, what we want to accomplish with the MCT. Then it's a module on depression. which is very close to CBT. We know that patients with schizophrenia often have depression. About 50% have a diagnosis of depression or another affective disorder, and self-esteem is very low. And this is one of the main reasons for suicide in the disorder. And as I said before, this is a target area that patients really want to work on. So it's not so much important for them to talk about delusions, hallucinations. What they suffer from the most are these emotional symptoms. And again, we do here CBT standard. This is about gain from illness. So we discuss with patients the short-term advantages of being deluded, because there are some patients, but of course the long-term negative consequences. And then, yeah, we have different examples. Again, CBT standard, so it's about selective attraction, overgeneralization, rumination, and as I said, in the beginning, we are also borrowing some exercises from MCT from Wales, like attached mindfulness. We also have other mindfulness exercises. So the MCT really is a hybrid. So it has some unique features, but it also incorporates material exercises from other therapeutic schools. So, and I'm not sure what this means. And this is from the stigma module. Here we want to instill patients with hope, to show them that they are not aliens, but we want to normalize certain phenomena. Here we talk about the prevalence of psychotic symptoms, which are not really low. For example, voice hearing is quite common in the general population. Even conservative studies is about 50%. And we do not want to convey to patients that we are all crazy, but rather to tell them, yeah, they are not aliens. This is something that is part of human experience. So these are figures. And it's also very important to convey to persons how they can communicate their illness to others in an understandable fashion that does not cause resentment. And we also tell patients they should be really cautious to whom to disclose their disorder. There's nothing sort of bad about being psychotic, but as you know, the disorder is associated with a lot of stigma, and therefore they should be very careful to talk to about having a diagnosis of schizophrenia. And so these are the core aims of the MCT. The first is normalization, so to err is human, but also to show that an escalation, an exaggeration of cognitive biases can lead to positive symptoms. We tell them to attenuate the confidence when there's not enough evidence, and if there are momentous decisions, then they should collect more information. So it's a backdoor approach, if you want, and it's to plant the seeds of doubt. So to be more doubtful in your experiences. And there are a number of studies on MCT now, more than important. A lot of these studies have been conducted by my group, but there are more and more international replications, also from Spain. So I'm not sure did tremendous work on MCT or EMC. There's also a study in Chile, China, and so on. And most of these studies have had a positive outcome. But there's one important exception. That is a study by Oskar et al. From the Danaher group, and we did not take this non-significant effects lightly because we were involved in the study. And that study was on acutely deluded patients. So they had very severe symptoms. And because of the study, we have now made some adaptations to the MCT so that we say that patients should be fit for group training, and also that there should have some distance to the delusional ideas. And for those patients, we also created a new variant called MCT Acute. And since that study, we also created the app and also stressed the importance of confidence. Here are the meta-analysis I want to quickly go through. This is an early meta-analysis by Eichler and Bernard, published in Schizophrenia Research, which is 11 studies. As I said, we now have 40 studies. They find a significant effect for positive symptoms, for delusions, and also show that it's fun to patients. So the subjective efficacy, so self-report by the patients is quite high, points D 0.8. Of course, this is a soft parameter. So, I mean, subjective efficacy is nothing that is considered a primary outcome. But this is quite important because patients often have low compliance, low adherence, and so it seems to be entertaining to patients. They like to come to the room, and this, of course, is a prerequisite for improvement or for regular attendance. Then this was essentially replicated in a later meta-analysis by Leo et al., who found short-term effects on delusions, but also in the long term. And again, small to medium effects which were significant. And this was again replicated, confirmed by Philip et al. 2019. And then I'm especially proud of the study that just came out this year by Penny et al. Considered 40 studies on 1,816 patients, and we found medium to large effects for delusions and almost medium effects for functioning, for psychosocial functioning, but also significant effects for self-esteem, for negative symptoms, and for hallucinations. And we are also proud that now some treatment guidelines have incorporated the APMC or MCT into their manuals. For example, both in Germany and also the Australian and New Zealand Psychiatric Organization recommends the MCT for training. And yeah, what's next? So as I told you, the MCT is available in 38 languages. You can download it for free. We also have a curriculum in e-learning, which you can take part in order to get to know how to administer the training, but this is not mandatory. So you don't have to do a curriculum. If you read the manual, which again is available for free, that's enough. We also have the EMC Plus. I think it's also available in Spanish. That's for individualized treatment, especially for those with acute symptoms. And so far, the results are encouraging, and I still think there's no room for self-complacency, because the effects are just in the medium effect size range, and it should be our motivation, our goal to have effect sizes like in anxiety disorders or depression, so that we have large effect, and that we now hope that the gap, which has not been evaluated so far in psychosis patients, and also the additional module happens. And we have also expanded the idea of metacognitivo training to other disorders, so you can download an MCT for depression, for OCD, and we also, at least in German and English, we have a version for depression in older adults, because older adults with depression have very different problems compared to younger populations. There's also an MCT for bipolar patients, but that is right now only available in German and English. Yeah, and of course I haven't done this all by myself. I would love to all the translators and my team. This was really teamwork, and I thank you for your attention. Again, sorry that I couldn't talk to you in Spanish.
Thanks for your presentation. Was inspiring. And I would like to know if you are doing something in the direction of treatment personalization, because I guess that not every patient benefits from this 8 or 10 module that you presented.
Yeah. 8 to 10 modules, that of course is a very short duration. Therefore, we encourage patients to take part in the second cycle. So for most languages, I think also Spanish, we have 2 cycles, so that we have up to 20 sessions. And this app should be used on a permanent basis. So this is something that encompasses 155 exercises, which sometimes repeat, and of course repetition is good in order that these learning aims are really internalized. And for patients with low insight, again, And with very severe symptoms, it's better if they take part in the MCT class, so the individualized MCT. And I would like to add that all the effects I was showing are add-on effects. So most of, or virtually all of these patients were medicated. So it's not that we say that MCT is a substitute for antipsychotic medication. So these are all add-on effects. And sadly, right now, psychotherapy is not at the stage that we can really compete with pharmacotherapy. But again, I think it's very, very important to do psychotherapy in patients with schizophrenia because many of these patients experienced horrific life events. So they were raped, they were abused, and so on. And to just give them medication is some kind of scapegoating for them. That as if the psychologist or the medical doctor does not acknowledge this biography and says, well, this is irrelevant, or perhaps this is even a false memory. So sometimes I think that medication adherence is actually improved through psychotherapy.
I was wondering if you could comment a bit on your results considering depression and OCD.
Yeah, as for OCD, there's also a meta-analysis by Philip et al. So she did a meta-analysis on MCT for psychosis, but also OCD, and there are 4 studies now showing that there are almost medium effects for OCD, but this OCD concept is for self-help. So we evaluated this online in the framework of RCTs, and so the effects are not as good as you would expect if it's clinician administered. And for MCT for depression, I think we now have 4 or 5 trials. I'm not the main developer of MCT for depression, but Lena Jelinek, and they are also encouraging. But I must also acknowledge that the MCT for depression is quite close to CBT. And I also would like to admit that MCT considers itself to be part of the CBT family. Yeah, we stuck to the name metacognitive training because patients found it cool. They find this better than cognitive jogging group or something like that.
Well, first of all, thank you for your generosity in sharing all this material.
We lost the war, we also lost.
And well, my question is in terms of, well, we know that the psychosis is a very wide, well, it has a wide spectrum of manifestations, so to say. And I was wondering if you do any kind of neuropsychological assessment screening or something to be able to differentiate between cognitive bias and cognitive deficits, as we know that there are, for sure, part of these patients that have some deficits and limitations, like harder limitations, so to say, that could influence the way we can work with them. And also, if you have any suggestion or recommendations in terms of when to apply this kind of interventions, as compared, for instance, first episodes versus chronic or more chronic.
Yeah, that's a very good question. So we have mixed groups. So sometimes we have prodromal patients, first episode patients, chronic patients in one group, and it's an open group, which has the advantage that it does not dry out. So patients sometimes start with module 1A, but also 5B, and yeah, so it's like a train that is going from one endpoint to another. And the rule of thumb really is if a patient is able to attend occupational therapy, you could also admit him or her to metacognitive training. The only thing really is that disorganization and paranoia shouldn't be too high. But if patients are able to attend group sessions in other contexts, then you could also apply it to MCT. And regarding neuropsychological assessment, this is also not inclusion or exclusion criterion, because the slides or the exercises are fairly easy to understand. So we often have patients with intellectual impairment, but also some who have above average intelligence. And we also look if this is a moderated for outcome, didn't find this. But as I said before, when patients are too acute, then the exercise, the pictorial material, the text is too complex, and then the MCT acute should be done, and this is far more easy. So we use simple language, less colors, because sometimes patients also with associated loosening then get lost if they are sort of bombarded with information.
Thank you.
Bueno, pues thank you again, Stephen. Muchas gracias por asistir y participar y nos seguimos viendo a lo largo de la jornada.